at the first instance with intravenous normal saline and insulin of 2 units per hour. But after 2 hours, his potassium was noticed to have fallen to 3.0 millimole per liter. Then potassium chloride was added to his infusion. Here we have the monitored management pattern of investigation that were done during his management. And we can see the pattern of the sodium. We can see at 0 hour he had hyperkalemia, which was falling through 6 hours, 12 hours, until 16 hours of monitoring. Initially, he had hypochloremia, but eventually the chloride increased through. The bicarbonate also was low, which depicts the ketoacidosis or metabolic acidosis, but we could see that the anion gap was initially high, which shows high anion gap, hypokalemic metabolic acidosis. We can see the glucose level also falling through during the management period. And we can see the plasma ketones, beta hydroxybutyric and acetoacetate. They were all falling through as the management continued under insulin therapy and intravenous fluid. It was initially also hyperphosphatemic, but eventually we can see how it fell through 6 hours, 12 hours, and eventually at 16 hours. The reference intervals are stated at the end of the table. Now, the plasma analyses are typical of diabetic ketoacidosis. We have hyperglycemia, hyperkalemia, hyperphosphatemia, and high anion gap metabolic acidosis. So it could be described as a typical form of high anion gap hyperkalemic metabolic acidosis with increased plasma creatinine level secondary to dehydration state in the patient. Now, with the therapy according to the table we have looked at, we can bring out the following points, which are to be noted. We saw the glucose decreasing all along. We saw potassium level also falling, and that was due to cellular uptake under the influence of the insulin that was being given. There was also reduction in phosphate to hypophosphatemic level, also secondary to cellular uptake. There was resolution of the anion gap due to metabolism of the circulating ketones, which were being used to generate bicarbonate. There was also decline in creatinine level, as we said, because the patient was being rehydrated, so the creatinine level also fell. Now, we have to note that the plasma creatinine in this patient will also be artificially increased at admission points because of possible positive interference in the traffic by acetoacetate, except if the method being used has overcome that positive interference. There are other stated positive interfering substances there, uric acid, ascorbic acid, and the like. Now, on this case, the standout information of take-home point is this group of patients with hyperkalemic anion gap metabolic acidosis do not usually require parenteral bicarbonate because the bicarbonate is going to be generated during ketone metabolism. And so, admission of bicarbonate in them can lead to what is called overshoot metabolic alkalosis, which will be error of management. The second case is that of the 38-year-old non-diabetic woman presented in semi-comatose state. She was treated again with intravenous saline and insulin 2 units per hour. But again, after 2 hours, her potassium was noted falling to a level of 2.5 millimole per liter, and then potassium infusion was equally added as in the first case. Now, we need to take note of the action of the insulin. We saw there was hypochloremia, which eventually increased, coming down to hyperchloremic state. And then we see that the bicarbonate remained low all through, unlike in the first case, wherein bicarbonate was increasing under the management. The creatinine level was also increased, which also fell through. Anion gap, of course, was initially high, but we can see the anion gap here that it fell to normal state. So we eventually have a normal anion gap, unlike in the first case that remained high anion gap. We saw the value of glucose here that it fell through the management period, and the bicarbonate and acetone also were falling through instead of rising as in the first case. We can see the phosphate level also hyperphosphatemic state falling down to hypophosphatemic state. Now, the patient aneurysm value, except for the hyponatremia, as I said, is similar to that of the first case. Nevertheless, there was a different response to the treatment in this second case as against the first case. We could say that bicarbonate did not rise in spite of the fall in the plasma ketone and anion gap level. Of course, the ketone level became normal and the anion gap became normal also. So, causing the initial hyperkalemic metabolic acidosis anymore, it became hyperuremic normal anion gap metabolic acidosis. There was also rise in plasma chloride and system, and of course, the high anion gap metabolic acidosis in this second case has been converted to an hyperuremic metabolic acidosis, which is associated with normal anion gap. So it's different from the first case, even though they are both diabetic ketoacidotic conditions. This particular response in this second case has been reported to occur in 30 to 40% of patients that present with diabetic ketoacidosis, and is been stated to be due to loss of ketone bodies, potential bicarbonate, rather than their metabolism by cellular uptake. Now, the standout information here is that it's very important to recognize this kind of response in this group of patients that will require bicarbonate therapy, unlike the first case in which we said it wasn't going to be necessary to give bicarbonate, or here the patient will be tipped into overshoot alkalosis. Because the only way the bicarbonate can be generated in vivo is by the kidney, and that will take some days. Why? Because the plasma pH is normally maintained within a narrow range of 7.35 to 7.45 by three interrelated mechanisms. Often at the first point of call or the first line of defense, and they only take minutes to act. After that is the respiratory system, which is the second line of defense in acid-base imbalance, which also take hours, while the renal system, of course, the clearance of bicarbonate in metabolic acidosis will take days to act. And so this group of patients in the second case, we need bicarbonate treatment. Now, this case 3 is also a non-diabetic man, 48-year-old, but the diabetes became uncontrolled. He's a Caucasian with diabetes mellitus for 6 years, but presented to our patient clinic because his blood sugar had been noticed to be rising in the past week. His parents were both diabetic, and at the time of diagnosis, his weight was 278 pounds, all of which supported the diagnosis of type 2 diabetes mellitus. His disease was initially managed with diet, exercise, and metformin, which is commonly called glucophage. 4 months later, with weight loss and exercise, his blood sugar plasma glucose was consistently under 100 milligrams per day. That is around 5.55 millimole per liter. And then his metformin was discontinued due to that achievement of good, or what we can call excellent glycemic control. He did well until 1 week earlier to the presentation time, when he noted polyuria, polydipsia, and the finger-free glucose rising above 200 milligrams per day. That's above 11.1 millimole per liter. He had been eating well, no nausea, no vomiting symptoms of dehydration, and he denies having any form of fever, chills, or cough, or nasal congestion, chest pain, abdominal pain, or dysuria. All these symptoms and signs were absent in this particular patient as a remedy. His blood pressure at presentation was 148/70, pulse rate 100, and the weight, of course, was high, and he was febrile. On examination, his skin, head, eyes, ear, nose, throat, lungs, heart, and abdomen were all normal on examination. The analysis in the clinic shows large amount of glucose and ketone bodies. This has to be well looked at, even though this patient was a type 2 diabetic mellitus patient with all the habitus of this. In this patient, we had the analysis showing large amount of ketone and glucose. Now, the question is, what is the least likely cause of his poor glycemic control? And if we are looking at it, which of the following is the least likely cause of his poor control or poorly controlled diabetes? Is it occult infection? Is it poor adherence to diet and exercise? Is it diabetic ketoacidosis? is it pancreatitis? So let's go over these possibilities one by one. Until 1 week earlier, this patient's diabetes had been well controlled for several years. Pancreatitis was therefore least likely cause of his uncontrolled diabetes because he had no history of pancreatitis and had none of the common symptoms of acute pancreatitis like fever, vomiting, or severe made epigastric pain radiating to the back, which normally give the patient a typical habitat when they are being examined. Now, poor adherence to medication and lifestyle issues are very common in patients with poorly controlled diabetes and should always be in the differential diagnosis. Comfort in patients should also be considered a patient with uncontrolled diabetes. Although this patient had no symptom of signs of infection, urinalysis was done to look for an upper urinary tract infection possibly, and surprisingly, so large amount of ketone bodies. Case continued, he was treated then for diabetic ketoacidosis. An additional person confirmed that he had a high serum ketone level, and the acidity was with a high anion gap consistent with diabetic ketoacidosis. No cultures were negative for any organism, and he was admitted to the hospital and treated with intravenous fluid and insulin drip at 6 units per hour. Within 48 hours, his anion gap normalized, and he was discharged on a regimen of insulin and insulin lustrum. A fasting C-peptide level done 7 days after his presentation was 1.9. In this chart, we can see his glucose at admission period and day one, how the glucose in the plasma fell through, the sweet carbon dioxide, how it fell through. The anion gap also got corrected, 7 to 17 millimole per liter. It became normal. Beta hydroxybutyrate on admission was high. Serum ketones were initially positive, but eventually on day 3 became negative. Now the C-peptide that was measured on day 3 was also normal. Now, this case is typical of what can be called diabetic ketoacidosis in atypical diabetes. Diabetic ketoacidosis is one of the most serious complications of diabetes. Many patients present with nausea, vomiting, and abdominal pain. And dehydration is often present because hyperglycemia leads to glycosuria and depletion in the volume of the plasma. Interestingly, these patients show none of these symptoms, and yet he has diabetic ketoacidosis. So it's called diabetic ketoacidosis in atypical diabetes. Diabetic ketoacidosis is increasingly being recognized as a complication in patients with type 2 diabetes mellitus. And since the mid-1990s, clinicians have become increasingly aware of the condition variably termed atypical diabetes, flatbush diabetes, diabetes type 1B, or ketotic-prone type 2 diabetes mellitus, which is the typical case we have here, in which patients, usually obese, present with diabetic ketoacidosis as the first manifestation. So one has to be on the lookout to see this possibility when it comes around. But they are subsequently found to have type 2 diabetes mellitus. These patients typically are of African American or African Hispanic origin or of Caribbean descent. Ketoacidosis results from transient suppression of beta cell function, because of which is specifically, but there are theories and postulations. A recent study comparing patients who have type 2 diabetes mellitus with and without diabetic ketoacidosis presenting with decompensated diabetes suggests insulinopenia as the predominant feature or the predominant mechanism through which this condition arises. That's atypical diabetes. For many of these patients, insulinopenia is transient. As the ketoacidosis results, beta cell function improves, and with adequate insulin, lipolysis is reduced, and so formation of ketone also gets to become normal. Now, what causes diabetic ketoacidosis? Looking at the following possibilities, which one do we think is the cause? Insulin resistance, insulin deficiency, glucagon excess, glucagon deficiency, insulin deficiency combined with glucagon excess, or insulin deficiency coexisting with glucagon deficiency. Let's look at them one by one. Diabetic ketoacidosis can occur when there is too much glucagon with not enough insulin. That's the pick. Because insulin lowers serum glucose level by promoting glucose uptake in the peripheral tissues and by inhibiting gluconeogenesis and glycogenolysis in the liver. Insulin is also anabolic. It inhibits lipolysis and adipocytes and thus decreases the amount of substrate that is available for the formation of ketone bodies. That's ketogenesis. So insulin can be found to be anti-ketogenic. Glucagon is the primary anti-regulatory hormone responsible for ketogenesis. In the presence of glucagon excess, malonyl CoA production will decrease, and this will unblock the carnitine acid transferase 1 and allow beta oxidation to occur, and that will eventually lead to ketosis, ketonemia, and then ketonuria. Therefore, the sequence initiating ketogenesis begins with a shift in the ratio of glucagon to insulin, so that there is a relative or absolute excess of glucagon and a deficiency of insulin. The deficiency of insulin accelerates lipolysis, provides more substrate for ketogenesis, while excess glucagon turns on the oxidative sequence for fatty acid in the organ liver. There are three ketone bodies, as we know, acetone, acetone, beta, and they have the equilibrium of formation and transformation. The concentration of insulin required to suppress lipolysis is only 1/10 of that amount that is required to promote glucose utilization. Thus, diabetic ketoacidosis is of common in patients with diabetes because they typically have enough insulin to inhibit lipolysis, and therefore they inhibit ketoacid formation, but they do not have enough insulin to promote glucose use in the systemic milieu. So these factors of diabetic ketoacidosis will be acute illness, age greater than 65 years, inadequate insulin doses, those that are on insulin antipsychotic drugs, or ethnicity. Again, let's look through these possibilities. Diabetic ketoacidosis is often precipitated by an acute illness, such as an infection, cerebrovascular accident, myocardial infarction, or acute pancreatitis. These acute illnesses induce stress in the body and therefore lead to increase in the counter-regulatory hormones like cortisol, adrenaline, noradrenaline, and glucagon. Inadequate insulin doses can also lead to diabetic ketoacidosis. Drugs that affect carbohydrate metabolism are also risk factors, and these drugs include glucocorticoids, thiazide diuretic in high doses. That is, the study have highlighted that it should be greater than 50 milligrams before the activity can be noted. Sympathomimetic agent and second-generation antipsychotic agent called atypical antipsychotic will lead to the atypical presentation of ketoacidosis in the type 2 diabetic people, such as clozapine and olanzapine, although some of these drugs are worse than others. The compound type 2 diabetes mellitus is more prevalent in African Americans and the Hispanics. Age is not a risk factor for developing ketoacidosis, as stated in the literature. In fact, diabetic ketoacidosis is the leading cause of morbidity and death in children with type 1 diabetes and can also occur in children with type 2 diabetes, particularly in obese African American adolescents. How do we distinguish type 1 from type 2 diabetes metabolic acidosis? It's replete in literature now that it's becoming a bit difficult because of a lot of changes in diet, obesity, and prevalence of obesity and other factors, leading to some difficulties in distinguishing between type 1 and type 2 diabetes. And we use C-peptide, islet antibody, and we use body mass index, and we use family history or hemoglobin A1C level. Type 1 diabetes is characterized by disruption of pancreatic beta cells, leading to absolute insulin deficiency. This process is usually mediated by autoimmunity, and thus testing for islet antibodies, as ICA, glutamic acid decarboxylase antibody, insulin auto antibody, IAA, and tyrosine phosphatase antibody are the most specific ways to distinguish type 1 from type 2 diabetes mellitus. It's not that these antibodies are not present in some patients with type 2 diabetes mellitus, but the titer is usually of very low value compared to that found in type 1 diabetes mellitus. Hemoglobin A1C level correlate with the mean blood glucose level over the previous 8 to 12 weeks. The hemoglobin A1C typically is elevated in both type 1 and type 2 diabetes mellitus. Therefore, it's not a useful distinguishing feature to differentiate type 1 from type 2 diabetes mellitus. C-peptide is made when proinsulin is cleaved into insulin, and C-peptide is released from endocytic vesicles with insulin in a usually lower in patients with type 1 diabetes, but they are not as useful as in the early phase of diagnosis and monitoring, rather than at the normal late course of type 1 diabetes. A family issue of type 1 diabetes is more common in type 2, but patients with either type 1 and type 2 can have affected close relatives. Patients with type 2 diabetes mellitus are generally overweight, with body mass greater than 85th percentile of their age and sex. In contrast, patients with type 1 are usually thin, not overweight, and usually have a recent history of weight loss. There are, however, exceptions, and some patients with type 1 diabetes have elevated body mass index, while some type 2 diabetes have been found to be thin as against the norm. So this particular patient in discussion continued to do well. He was discharged from the hospital on insulin regimen, and his blood sugar level were closely monitored and remained near normal. 6 months after the episode of diabetic ketoacidosis, his insulin was also discontinued, and he did very well. Now, from this case, the wrap-up point or the standout information is that diabetic ketoacidosis is not unique to type 1 diabetes mellitus. It can occur in type 2, more commonly in patients who are non-white or of African origin or African American origin, and who have preceding factors like acute illnesses, inadequate insulin treatment, or newly diagnosed diabetes mellitus. Laboratory physicians and clinicians should be aware of the possibility of diabetic ketoacidosis even in patients with type 2 diabetes who may not have these stated risk factors. The risk factors are not sine qua non for diabetic ketoacidosis to take effect when it comes up. So one approach to recognize diabetic ketoacidosis better in patients with type 2 diabetes mellitus would include checking urine for ketones and serum electrolyte for high iron acidosis when patients with type 2 diabetes mellitus present with uncontrolled label or uncontrolled blood glucose level. If ketonuria or acidosis is present, serum ketone and beta hydroxybutyrate levels will be obtained to evaluate for diabetic ketoacidosis. Patients will take insulin for an indeterminate period of time after initial treatment of diabetic ketoacidosis. As this case illustrates, in many cases, beta cell function will return sufficiently to allow insulin to be discontinued in most cases. There are no clear guidelines for how long to continue insulin, but most practitioners continue it for weeks, months, and continue it when the glucose levels are stable and remain so with different doses. Sometimes oral agents need to be added as insulin is tapered off in such patients. Insulin therapy is tailored to the individual presenters, precision medicine and personalized medicine. And there are no data on the type of insulin that is most effective in such cases. And there are also no data on whether this patient are at greater risk of hypoglycemia than other patients taking insulin. In general, there is no evidence that prophylactic insulin, giving insulin to prevent diabetic ketoacidosis in such cases, will actually prevent it from happening. However, blood glucose monitoring is appropriate during the person of stress or when any of the factors related to it are noted, and this will be carried on as appropriate for preventive reasons. Now, the final case is what is called hybrid diabetes mellitus. Now, a diagnosis of type 1 diabetes was made in a particular case of 17-year-old girl. This girl is actually a Nigerian girl and is published in Pan-African Journal. After she presented acutely with features consistent with diabetic ketoacidosis at the age of 11 years, she presented with osmotic symptoms, that's polyuria and the like, a random blood glucose level of 28.4 millimole per liter, ketonuria of 3+6, and glycated hemoglobin of 11%. The diagnosis of type 1 DM was made based on the high levels of autoantibodies. Again, we see the antibodies coming up here again. They are specific if they are found at particular cut-off levels, like anti-glutamic acid decarboxylase antibody and anti-inflammatory antibodies, and low level of C-peptide was found in this particular patient of 17-year-old. The patient body mass index at the time of initial diagnosis was 28.3, with no marker suggestive of insulin resistance like ketosis nigricans. Screening for antibodies suspected with possible autoimmune thyroiditis were also negative. Also, there was no evidence of dyslipidemia and blood pressure was within normal range. She was put on insulin treatment, total daily dose of 92 to 122 units per day with subcutaneous insulin, a long-acting analog, and regular insulin at bedtime and also before 3 meals, respectively, since she was discharged from the hospital. There was no history of clinical evidence that would suggest polycystic ovarian syndrome, as her menstrual sample was regular with no hirsutism or acne. However, 6 years after diagnosis, she was 11 years old at the initial diagnosis with type 1 DM, but when she became 17 years old, she was noticed to have developed diffuse widespread acanthosis nigralis adrenal neck and axillary region, indicating insulin resistance as specific, and her weight increased significantly compared to when she was diagnosed with type 1 diabetes mellitus 6 years earlier. Her BMI became 33.4. However, her BP fasting lipids were still normal. Thus, with these new features in this particular patient, she was diagnosed with type 2 diabetes on a background of type 1 diabetes, and this is described as double diabetes. Moreover, she was canceled lifestyle modification, diet, and exercise, and metformin was given twice daily, added to her initial insulin dose based on the initial diagnosis of type 1 DM. Within a period of 2 months, our daily insulin requirement reduced from 90 to 122 units to 48 units, and this was with significant improvement in our glycemic profile, leading to hemoglobin A1C value of 8.3% from initial value of 11%. These are the results of our biochemical profile. At the initial diagnosis, he was 11 years old, 6 years later, 17 years. At the initial diagnosis, there was DKA, but later, after she presented with those features suggestive of insulin resistance, there was no DKA. BMI was initially 23 and became 33.4, which tends towards diagnosis of type 2 diabetes. Fasting C-peptide remained normal. Antibody were elevated at both instances, both at the initial stage of diagnosis and later. Anti-insulin autoantibody was initially increased and remained high at the second instance. The anti-thyroid antibodies remained negative, and hemoglobin A1C fell from 11% to 8.3%. Insulin subcutaneous was used initially, but eventually she was given metformin and lifestyle modification. Total daily dose of insulin at the initial stage was 92 to 122, but eventually became 48 units necessary for our control. This is a picture of our acanthosis nigricans around the neck. Now, diabetes mellitus is a metabolic disorder, as we all know, characterized by chronic hyperglycemia, that's fasting plasma glucose greater than the cutoff point, or 7.1, or random of 11.1, and hemoglobin A1C greater than 6.5 millimole per liter. The major causes of diabetes mellitus are those of type 1 and type 2. Other specific types were so-called gestational diabetes mellitus and the like, and other variants. Classically, a patient with a positive issue of diabetes in first-degree relative to obesity, weight loss, absence of both diabetes associated autoantibody, that is anti-diet antibody and insulin autoantibody, and ketone bodies with symptoms of polyuria, polydipsia, and polyphagia have been specifically diagnosed as type 2 diabetes. However, type 1 patients mostly have habitus, ketonemia, and diabetic ketoacidosis associated autoantibodies. Also, previously, the symptoms between type 1 and type 2 diabetes have been based on age at onset of disease, the relative or absolute insulin deficiency, and dependence on insulin or not since after diagnosis. However, with the rising incidence of obesity among children and adolescents, type 1 and type 2 diabetes mellitus cannot be easily differentiated on the basis of only clinical features, and causal factors as beta cell inefficiency is important and central in both conditions as related to their pathogenesis. There is evidence that supports the hypothesis that type 1 diabetes mellitus, that is fast diabetes similar to type 2 slow diabetes, will eventually cause insulin resistance, with obesity contributing significantly in this development. A different type of diabetes has thus been reported in children and adolescents, and this is designated double diabetes, hybrid diabetes, or some other people call it type 1.5 diabetes mellitus. Double diabetes represents an entity presenting in childhood and adolescence which combines characteristics of type 1 positive autoantibodies and type 2 obesity and insulin resistance with a strong family history of type 1 and type 2, which progresses rapidly to insulin dependence or occasional reduction in insulin dosage with addition of insulin sensitizer medications, especially metformin. An adolescent with persistent type 1 or type 2 and that features of double diabetes, which could be simultaneous with initial diabetes diagnosis or develop later in subsequent monitoring period. For example, in the patient with persistent type 1 diabetes mellitus, the development of features of keeping with type 2 is greatly influenced by rapidity of weight gain and obesity, plus the genetic factors. A typical patient is usually overweight or obese and requires high insulin doses to work. On the contrary, about 5% of children with type 2 diabetes mellitus have at least one diabetes onset, and I said earlier that these antibodies can be present in type 2 diabetes mellitus patient, but they are usually of low titer value. This case in this teenage girl who first presented with type 1 and type 2 diabetes mellitus. There is paucity of data on the occurrence of double diabetes in Africa and especially in Nigeria. Summary: double diabetes, otherwise known as type 2 diabetes or type 1.5 diabetes, is a new variant, and it's a combination of both type 1 and type 2 diabetes in children and adults. It's a diabetes variant increasing in prevalence in developed countries because of epidemic obesity among children and adults, but is currently said to be extremely rare in developing countries. Double diabetes is characterized by features of both type 1, diabetes autoantibodies, and of course, features of type 2, obesity and insulin resistance. The occurrence can either develop on the background of type available to take on, whichever one is peculiar in such individual patients. The variant has been linked to possible increased cardiovascular risk and worsening morbidity, including poor glycemic control. The take-home point here is that a new expression of diabetes mellitus specified as double diabetes, hybrid diabetes, type 1.5 diabetes, resulting from global pandemic of obesity in children and adolescents, encompass autoimmune entity of type 1 DM and that of the metabolic component of insulin resistance and type 2 DM. Presently, there is no consensus on the best therapeutic approach for this new variant of diabetes mellitus, although the use of weight-losing anti-diabetic agents would be a good option in addition to insulin therapy. These are my references, and I thank you for your rapt attention. Thank you so much.